Hello, everyone, and thank you for joining us for this webinar update on measles, stories from the front lines. I'm Dr. Sandra Fryhofer, AMA's liaison to ACIP, the CDC's Advisory Committee on Immunization Practices, and I'm delighted to be your host for today's discussion. Today's webinar is brought to you in collaboration with Project First Line, CDC's National Training and Education Collaborative for Infection Prevention and Control. Project First Line works with its partner networks to provide innovative and accessible infection control education. Its mission is preparing frontline healthcare professionals and public health workers on how to protect themselves, their patients, and their communities from infectious disease threats. AMA is proud to be a Project First Line partner, and we're so thrilled to have colleagues from CDC and other organizations here with us today to share their knowledge and firsthand experience with measles. Measles was declared eliminated in the U.S. in 2000. Enough people were immunized to make outbreaks uncommon. But this year, we've seen outbreaks popping up in communities where vaccination rates have slipped below what's required to maintain community immunity. In our March webinar, we discussed the need to be on alert for travel-associated measles. Since that time, the number of new cases has declined, but we're not out of the woods yet. And that's the reason for this update today. Joining us today are representatives from the Pediatric Pandemic Network, the American Nurses Association, and the American Academy of Pediatrics. These clinicians have firsthand experience caring for and preparing their facilities for patients with measles. They've learned valuable lessons along the way, and they've graciously agreed to share their stories, insights, and best practices with us today. But first, CDC's Dr. Filardo will set the stage and update us on the current state of measles in the U.S. Dr. Filardo is board certified in both internal medicine and adult infectious diseases. He got his MD from the University of Michigan, followed by an internal medicine residency at the University of Colorado, and then a fellowship in infectious diseases at NYU. Dr. Filardo joined CDC as an EIS, Epidemic Intelligence Service Officer, in 2021. He's also been the medical officer for CDC's Measles, Rubella, and CMV epidemiology team since 2023. Dr. Filardo, welcome. When it comes to measles right now, where do we stand?
Yeah, great to be with you today. So I'll review some of the information that's available on CDC's website regarding the current status of measles cases and outbreaks in the U.S. And currently, CDC is updating our website every 2 weeks. So far during 2024, as of the last update on June 13th, there have been 151 measles cases reported by 22 different jurisdictions in the U.S., and there have been 11 outbreaks, which we define as 3 or more cases which are related by transmission. 2/3 of all cases have been associated with outbreaks this year. And the biggest outbreak of 2024 occurred in Chicago, Illinois. And in total, 57 cases were directly linked by the Chicago Department of Public Health to an outbreak which occurred within a large shelter setting. And this outbreak has been declared over by the Chicago Department of Public Health, meaning that we are 2 full incubation periods for measles, or 42 days after the last diagnosed case in the outbreak. During this year, about half of cases have affected children under 5 years of age, and about 1/3 of cases have affected adults over 20 years of age. And similar to prior years' data, the majority of measles cases have occurred among people who don't have documentation of measles vaccination. So during 2024, 83% of cases have been among people who were known to be unvaccinated or had an unknown vaccination status. Measles can cause complications such as diarrhea, dehydration, and pneumonia, and can lead to hospitalization in about 1 in 5 cases, according to our national surveillance data since 2000. Another cause for hospitalization would be if people with measles aren't able to isolate where they are living to prevent spread of measles to others, and they may require hospitalization purely for isolation. And this definitely occurred during the large outbreak in Chicago in a congregate setting. So as a result, this year our numbers are a little bit higher than typical, and 54% of reported measles cases so far this year have required hospitalization, either for isolation or for management of measles complications. So measles activity in the United States has definitely slowed since the end of the outbreak in Chicago, but we do continue to see periodic importation of measles cases, which then lead to either limited transmission or small outbreaks of less than 10 cases during the sort of middle part of this year. And measles activity definitely continues globally, with many countries across the globe right now experiencing large and disruptive outbreaks. So far this year, most importations of measles into the US have been related to travel to either the WHO European or Eastern Mediterranean regions. So with summer travel for Americans really getting into full swing, we're trying to get the word out about our recommendations for measles prevention in the context of international travel. So as a reminder, the recommendations are that all people over the age of 12 months should have 2 documented doses of MMR prior to international travel. And that's even if they haven't reached the typical age at which you get a second dose, which is between 4 and 6 years of age. And this is also true for adults who might not otherwise have a reason to get 2 doses according to the standard recommendations. So across the board, everyone over 12 months of age is recommended to have 2 doses of MMR, and ideally at least 2 weeks prior to international travel. And the other difference in the travel recommendations compared to the routine is that CDC recommends a single dose of MMR for infants between 6 and 11 months of age prior to international travel. And this is before the first routine dose is given after 12 months of age. And just to highlight, this recommendation is regardless of destination outside the US, since measles cases and outbreaks can occur anywhere in the world. We're especially focused right now on Europe, just given that there has been a surge in measles cases in the European region. And this is also a destination where travelers may not really think about the kind of travel vaccination or other prevention measures they might need before they travel. So that's all for my update, and thanks again for the opportunity to be with you today, and I'm happy to answer any questions that come up in the Q&A.
And we'll take you up on that later on in the program. So thank you for that timely update, and it's such great information to have as people make their vacation travel plans for the summer. So now I'd like to introduce our other 3 panelists for today. Dr. Ayelet Rosenthal, attending physician in the Division of Infectious Diseases at Lurie Children's Hospital in Chicago. She received her MD from the Hebrew University School of Medicine in Israel. This was followed by a residency in pediatrics at Rutgers, New Jersey Medical School, then fellowship in pediatric infectious diseases at Stanford. She's now assistant professor of pediatrics at Northwestern University's Feinberg School of Medicine and also medical director of infection prevention and control at Lurie Children's Hospital. Her clinical and research interests include diagnosis and prevention of healthcare-associated infections, infection prevention education, and care of children with immune-compromising conditions. Dr. Rosenthal was a co-lead for institutional response during the recent measles outbreaks in Chicago. Dr. Rosenthal, thanks so much for being with us.
It's good to be here. Hello.
Our next panelist is Dr. Betty Boyle-Duke, who received her doctor in nursing practice degree at NYU. She's a nurse practitioner and nurse administrator specializing in pediatric and adolescent primary care. She completed her nursing education at Simmons University in Boston. She's worked both in hospital and outpatient settings. She's currently Associate Director of Nursing at the Student Health Center at Barnard College in New York City. In that role, she oversees RN staff, as well as infection control training, policy creation, and compliance. She also has several academic appointments. She's Assistant Professor of Nursing at Long Island University School of Nursing and also adjunct faculty for the University of Haiti's nursing program. Welcome, and many thanks for joining us.
Thank you so much for the invitation. I'm glad to be here.
Our final panelist is Dr. Brandon Chatani, a pediatric infectious disease consultant for AdventHealth for Children in Orlando, Florida. Dr. Chatani got his MD from Temple Medical School in Philadelphia, then relocated to Miami to complete his pediatric residency and fellowship in pediatric infectious diseases at Holst Children's Hospital. Dr. Chatani exhibits a deep passion for pediatric care, infectious diseases, and community advocacy. From actively participating in the Antimicrobial Stewardship Program and the Pediatric Liver Transplant Selection Committee, to assuming leadership as chair of the Florida chapter of the American Academy of Pediatrics Immunization Committee, His dedication to optimizing patient care and advancing healthcare policies has remained unwavering. Dr. Chatani, thanks for taking time to be with us today.
Thank you for having me.
So now that you've met our speakers, let's hear their stories. Dr. Rosenthal, we'll start with you. You've been on the front line of the measles outbreak in Chicago. Please tell us about this experience.
So hello, everyone. I'm going to talk about the measles outbreak in Chicago and talk specifically about the experience in our pediatric hospital, Lurie Children's Hospital. Next slide. I'm just going to give a quick review about the measles outbreak in Chicago. This year, we had 64 cases of measles here in the city, with the first case identified in the beginning of March. As you know, the best way to mitigate measles is by giving vaccines. And I really want to highlight the amazing job that was done here by the Department of Health, giving more than 33,000 vaccines to unimmunized individuals, especially in shelters where most of the cases came from. Next slide. When we heard about the new cases in Chicago and the prediction of getting more cases of measles, we had a few considerations here in the hospital. So first of all, we are a pediatric hospital, a big pediatric center in the middle of Chicago. So we had to prepare for an influx of patients coming to seek care, evaluation, and we needed to give this care a good medical care, but also in a safe manner, in a way that we prevent measles transmission within our hospital. And this meant that we needed to quickly notify our emergency department and our urgent care stakeholders about the cases in Chicago and prepare them of what to do in order to quickly identify and isolate patients coming to the emergency department with our guidance. We very quickly implemented operating procedures in our high-risk areas to be able to isolate the patients promptly to prevent transmission within the hospital. And we need to understand that most of us as clinicians actually never saw measles outside of the textbook because, as you said, measles was considered eradicated. So we needed to give what I call a clinical refresher to providers, both infectious diseases and frontline providers in our ED and urgent care, about what is the diagnosis and how to make the diagnosis of measles, because this is mainly a clinical diagnosis, and also explain the testing processes for our patients. We also wanted to follow the WHO recommendation of giving vitamin A to patients with measles, especially those coming from low-income countries, like the patients who had measles in our city. So we contacted the pharmacy to make sure that we have enough vitamin A to provide, and preparing for the possibility that we'll need to provide post-exposure prophylaxis and making sure that we have enough IgIM in our pharmacy. And most importantly, continue collaborating and communicating with the Department of Health during this outbreak. Next slide. So as part of the infection prevention and control measles response, what did we do? So as soon as we heard about the measles case from late February that was reported at the beginning of March, we participated in a health department check-in, and also within the institution, we participated in stakeholder huddle to notify them about the new cases and making some required preparations. We also eventually opened what we call an incident command involving hospital leaders and the stakeholders to give daily updates about the amount of patients who were admitted, amount of patients seen in the emergency department, how many urban isolation rooms were used, and whether or not we need to consider opening other rooms or finding other solution in case we get more patients. We very quickly after the first case was identified and we were notified, we actually drafted and finalized an emergency department and immediate care standard operating procedure, so we can educate and have a procedure for quick identification and isolation of patients seeking care in our hospital, whether coming to seek care or being transferred from by the Department of Health or from other institutions. Later on, we developed other SOPs for other teams that could have seen patients coming with possible measles, such as our transport team, for example. And we continued close communication with all of these teams. We conducted education to ED and immediate care staff, and we had ongoing huddles with stakeholders and subject matter experts within the hospital. We implemented, of course, measles signage in the emergency department and in immediate care areas. Next slide. So this is an example of our ED measles SOP, and these are very small. This is very small print, and I do not expect everyone to actually read it, but just to show how it's built and how we build it. The idea was to provide some screening tests, taking into account symptoms that can be associated with measles alongside exposure criteria that was provided to us by the Department of Health. And it kind of shifted throughout the outbreak to allow the screeners, the entrance to the, once the patient came to the ED, to promptly identify and isolate the patient. We followed, of course, the algorithm of identified, and isolate and inform. And of course, it didn't just stay on paper. All of these screening questions were implemented into the electronic medical record. So things just popped up. So if the patient met a few criteria through these questions, a notification was noted in the computer that they needed to be isolated. Next slide. Just to summarize our experience here more on the clinical side. So here in Lurie, we saw a total of 17 both suspected and confirmed children with measles. Confirmed measles cases, we had 6 patients. 11 of these patients were tested at Lurie ED, and 8 of the patients were admitted. 5 of the admitted patients had a positive test. 1 was a false positive, and 2 had a negative test. Again, as Dr. Filardo said, the reason to admit these patients was not necessarily because they clinically needed to be admitted, but because they could not go back to their congregate setting and they needed the isolation during the infective period between them 4 days prior and 4 days after the initiation of the measles rash. I just want to note that 4 of our patients here were transferred from another hospital due to the need of isolation. You can see in the graph here that the majority of the actual positive measles patients in our hospital was actually during 1 week, and I am proud to say that I was on call during this week. Next slide. For the patient's characteristics, the mean age of our patients here was 25.5 months. The mean admission day was 5.6. And here just to pause and say that most of the patients came actually about 2 days, 1 day after the initiation of the rash. So they didn't require a long hospitalization. Usually within 2 days, they were no longer admitted. The reason we see such a mean is because one of the patients had pretty complicated measles and had such a prolonged hospitalization that it affected our mean. 100% of our patients came from a congregate setting, from a shelter. And interesting, 100% of the children, as I noted at the beginning, that the Department of Health provided vaccinations for many of the residents. 100% of our patients, our children, had 1 dose of the measles vaccines, but unfortunately, they were not yet immune at the time when they were exposed to measles. To remind that it takes about 21 days from getting the vaccine to actually developing immunity, and they were exposed during that time. 100% of the patients presented with fever, 100% presented with a rash. So as I said, for many of us, it was a textbook disease by the time the outbreak was done. We feel comfortable identifying a measles rash. 83% presented with a cough and with a coryza, and 33% with the conjunctivitis that we see in the pictures of measles. One of the patients had very severe complication of measles. Interestingly, the patient also had varicella 3 months prior, and he was not vaccinated. The patient had measles pneumonia and later on complicated by MRSA, complicated superimposed bacterial infection requiring a chest tube. I'm happy to say that he did well and was discharged from the hospital after a short ICU stay. All of our measles positive patients received vitamin A per the WHO recommendations. And we also assisted 5 non-immune pediatric patients to receive post-exposure prophylaxis here in our emergency department. we were contacted by one of our neighboring adult clinics where they had exposure to one positive patient in their waiting room. And we helped with identifying the non-immune pediatric patients that were eligible for PEP and provided IgIM, and none of them developed complications or had a positive measles test later on. This is it for me, and I'm looking forward to answering all the Q&A.
Well, Dr. Rosenthal, thank you so much for your insights and for all your hard work in caring for your community. And we will have some questions later on, and hopefully if we have time. Dr. Boyle-Duke, we would now love to hear from you.
Great.
Here at Project First Line, we focus on the importance of infection prevention and proper precautions. So what have you learned about IPC, infection prevention and control, and measles?
Thank you. So yes, I would like to cover some best practices for infection control and prevention, in particular as it relates to measles in various healthcare settings. So all healthcare settings should have ICP guidance as part of a comprehensive infection prevention program to prevent transmission of all infectious agents among patients, healthcare providers, and visitors. This should also include not only preventative measures, but also I'd like to cover areas that pertains to necessary items for disease management and maintenance as well. And Dr. Rosenthal actually covered some of this as well. Next slide, please. So key elements to consider for inclusion in creating policies and procedures as part of a comprehensive infection control plan in measles prevention would be elements that encompass the following, and I use this pie chart for some areas of concern. So aspects for prevention of illnesses such as measles from occurring at all in terms of prevention, details for managing cases if they're suspected or confirmed cases of measles by utilizing triaging measures, as well as telehealth. Also, the third part of the pie is what I refer to as aftercare, and that is some areas of concern in terms of looking at minimizing the spread within a facility. So this three-part figure flows, each component flows into one another because oftentimes each part will overlap, so it's not static, just so you understand. And we know that measles is one of the most contagious infectious diseases, so key measures to prevent the spread in various healthcare settings really should have a multi-pronged approach, which I'll discuss. Next slide, please. So for prevention, some of the things that are important to ensure infection control policies are up to date. Having a dedicated coordinator or infection control prevention officer, whatever title your facility would like to place with that, to have regular updates made to your policies, and if any clinical guidelines or guidance changes, that changes are made expeditiously. And as healthcare settings also within prevention is having a robust onboarding immunization policy. So healthcare centers can ensure healthcare workers have presumptive evidence of immunity through vaccination records or titers or record of having the illness in the past. That would indicate immunity from measles. And in college health here, we require proof of immunity from our providers as well as our patients, the students that are upon enrollment in college. So similarly, in the outpatient setting, it's an opportunity for providers to review healthcare records at each encounter of their patients to ensure that patients are up to date with vaccines, including MMR, as age appropriate. I believe every encounter is a perfect timing to avoid a missed opportunity to engage patients regarding their immunization upkeep. This also ensures if a case of measles were to occur, that providers caring for the patient have a level of protection with immunity from measles. So in addition to minimizing potential measles exposures, it's important to communicate with staff of local outbreaks through the health alerts that may come out, and also any communication if there's special arrangements that need to be made if a patient's arrival to a healthcare setting. If measles is suspected when scheduling appointments, is also important to have a communication plan included in that in that infection control policy. Next slide. So for that second part of the pie, when we talk about management, one of the things that is helpful is the use of triage and telehealth. And that can be done using symptom checklists. Dr. Rosenthal actually had an algorithm that was used as well, that if you have a patient who presents with certain symptoms, that you'd be easy. One of the key things is to rapidly assess if this patient has possible measles. And this is especially important for nurses or the front of office staff who may first encounter the patient. It's important to ask these questions, whether using a checklist in your EMR, or if you have the ability to do telehealth with a platform with video, that's a plus, because if they have a rash, you'll be able to see the rash as well. And also, it's important to have, if there's a concern for measles, that respiratory precautions are being are put in place. And so it's important to have PPE available for all of those staff, as well as patients coming in as well. For the checklist, for symptom checklist, some of the things that you can include, which Dr. Rosenthal touched on with some of the patients that they saw at her facility, asking questions around, is the patient febrile? Is there a rash that developed? If the rash is present, where is the rash? What does it look like? Also, what is the pattern of the rash? Is it cephalocaudal? Is it developing from head to toe, which is important and often unique to the rash that's associated with measles? Are there spots in the mouth that's possibly consistent with Koplik spots in the buccal mucosa that also could be indicative? Are the 3 C's present? Coughing, coryza, and conjunctivitis. Was there any recent travel? These are all the questions that could be asked in that checklist or in that algorithm or EMR template that could be utilized. And most importantly, one of the important questions is recent exposure to measles, because that's a telltale sign as well. And then for PPEs, as stated, with having standard and airborne precautions in place, it's important to have measures in place so that people are able to adhere to those precautions. We know that measles is spread through direct contact with respiratory droplets, as well as aerosolized transmission, which can hang in the air for some time. So persons with signs or symptoms of measles should be identified, provided a face mask to wear, and separated from other patients prior to, as soon as possible, upon entry into the facility. And those caring for patients need to have N95 respirators, fit test respirators, or powered air purifying respirators, which provide a higher level of protection available to wear. And again, this is where the knowledge of knowing the staff's immunity status that I mentioned before is important. Having those who may not have immunity, those who are immunocompromised or possibly pregnant, not be involved in direct care for these patients would be preferable. And then once identified as a potential measles case or confirmed measles, patients should be immediately placed in isolation. So having an isolation plan as part of your comprehensive infection control policies is important. What is that dedicated space? In the outpatient setting, it should be a dedicated space for isolation that's away from other patients, preferably not an exam room. As I stated, we know that measles can stay in the air for some time. So if you use an exam room, that exam room will be out of commission for some time, which could affect patient clinic flow as well. That room should have a HEPA filter if it is in the outpatient setting. In the inpatient setting, you can certainly use a room with negative pressure, where the air is rushing inward and not outward, such as an airborne infection isolation room, which is key to have. Posting visual alerts is also very important. Signs and posters in appropriate languages about respiratory hygiene, cough etiquette, and hand hygiene at the facility entrance and in common areas. So for the waiting rooms, elevators, cafeterias, it's important to educate the community, as we are in a to mask or not to mask stage in these, some people say, post-pandemic times. Providing people with signs or symptoms of measles with instructions on relevant infection control expectations is also important. So if you have a patient that comes in and now they're going to be placed in isolation, they may be separated from the person who brought them in, those expectations need to be made and clear with the patient. And then PPE should be available for all persons in the facility. And it's important to have these supplies, such as face masks, near the visual alerts. If you have signs that say, if you have fever, cough, rash, please place them. Let the front desk know or put a mask on, but the masks aren't available next to the visual alerts. That's sort of a misstep. So it's important to have mask stands next to these visual alerts. Next slide. And then what I refer to as aftercare. So measles, we know, has been reported to survive in the air for up to 2 hours. So it is important to have a communication alert system in place for interdepartment consideration. Environmental services or housekeeping or other allied health partners that may be involved in the patient care should avoid entering the space for 2 hours after the patient has vacated for cleaning or any other necessary tasks that may be necessary to avoid their potential exposure. Cleaning and disinfection should be specified to include the use of disinfectant like EPA registered disinfectants, and the surfaces should be pre-cleaned with water or cleanser prior to disinfecting the surfaces. So that extra layer needs to occur. As I stated regarding the checklist, another way that is important for the environment after a patient has come in is to have an exposure checklist. And that's really to help with contact tracing if any other patients or visitors were in the waiting room or in the same space when the patient presented, as those individuals need to be evaluated for possible exposure as well. So some of those checklists are helpful in that way. In regards to the inter-department, if for some reason we're seeing a patient, and I think Dr. Rosenthal talked about having to transfer patients, whether it be because I'm in the outpatient setting. So if a patient needs a further level of care because of their symptoms, or I think Dr. Rosenthal mentioned about isolation, but in the event that we have to transfer patients, instructing emergency services of the patient's diagnosis, as well as the receiving facility, obviously, that this is known or suspected measles. And the plan should include measures for employees who may be exposed without immunity. As it's important to have a way to offer vaccinations as a post-exposure prophylaxis as soon as possible. And then the last thing that I will say overall to ensure that policies are widely known and enforced, and something that I think is helpful, one way is using mock codes. So infusing infection control aspect as part of scenarios during mock codes is a great way to review exposure plan when you debrief as well. And that way the exposure plan is not just reviewed on an annual basis, it's actually infused throughout your academic year or through your continuing education with staff. For example, you can infuse, it's a measles outbreak, or you have a toddler who's febrile, has febrile seizures, and they have measles. And that way, all of the staff can think about some of those key elements that need to take part with someone who has measles. And the codes should include all staff who may encounter patients, so everyone knows their role during an outbreak. And also training people on quick recognition of measles to minimize the spread or exposure at all entry levels of the healthcare visit. So I think that's my last slide. Thank you.
Well, thank you. That was a lot of great information, and we really appreciate you taking the time to talk with us and sharing your expertise. Dr. Chatani, you're up next. Most measles cases do not need hospitalization as there's no specific treatment for measles. But what lessons have you learned on the outpatient side of measles prevention, identification, and care, including public health coordination and reporting?
Thank you so much for having me, and thank you for that introduction. What an amazing discussion that we're having now about how to identify measles, how to report it, and really how to best protect our communities. And understanding and implementing effective triage procedures is essential in our healthcare settings because it ensures that we identify and manage potential exposures promptly. Equally crucial in our fight against measles is our approach to vaccination. By integrating vaccination history into our triage processes, we not only improve our immediate response, but also identify opportunities to bolster immunity within our communities. So now let's delve a little bit deeper into the strategies and best practices for measles vaccination specifically. This involves recognizing critical windows for vaccination, addressing parental or patient concerns with empathy, and leveraging effective communication techniques to increase vaccine acceptance. As healthcare providers, we understand the importance of discussing vaccines with our patients, even though it can be very challenging. It's a topic that stirs strong emotions and deeply held beliefs, but it's also among the most crucial conversations we can have to safeguard the health of our children and communities. Recognizing opportunities for measles vaccination is particularly critical in the outbreak setting. If a preschool-age child is at risk due to outbreak location or transmission settings, then a second dose earlier between the 1 and 4 years can be considered. If an infant's at risk, I believe it was mentioned that infant can receive the 0 dose, meaning that they get that dose, but then technically their first dose is counted after 1 year of life. It's essential to approach these conversations with empathy and understanding rather than authority. Dismissal of hesitant families might seem like an option, especially when we all face so much burnout. However, this approach doesn't address underlying concerns and can jeopardize public health. Instead, we advocate for a partnership approach. By validating parental concerns and seeking permission to share information, we respect their autonomy while providing accurate evidence-based information. For instance, asking, could I share a few things I've learned about vaccine safety with you? It opens a constructive dialogue. So not only are you saying these words so you yourself are put into that setting and open-mindedness and non-judgmental tone to engage in a difficult conversation, but also the patient is set at ease that you are inquisitive of why they're hesitant about vaccines and are open to whatever the conversation may be. We also have other effective tools at our disposal, such as presumptive approach, motivational interviewing, and persistence, which are proven to increase vaccine acceptance. These methods enable us to engage respectfully, understand parental perspectives, and align vaccination decisions with their values. As healthcare providers, again, we play a unique role in building vaccine confidence through our long-term relationships with families. So every interaction is an opportunity to reinforce the importance of vaccinations, dispel myths, and provide reassurance based on scientific evidence. This happens door to door in your practice. So from the first person that interacts with that patient to the last person that interacts with that patient, every person has a moment that could present as an opportunity to identify and address patient concerns about vaccines. Now, not every front desk or MA is going to feel comfortable with addressing vaccine concerns, but they are presented at least with the opportunity to empower that family or patient to bring up those concerns to the provider that's going to be best to address them. They are their hype person, their hype man, to say that they are more than willing to address those concerns and to make sure that the patient feels heard and that we can address them as necessary and build that confidence. Much of the same approach can be used for staff and providers in your practice that have hesitancy to really confidently give that strong recommendation for the measles vaccine, for example. We want to get all of our staff and providers to give their strong recommendation confidently. This mostly involves motivational interviewing with the staff, educational sessions, and persistence in getting everybody on board to be confident with what this takes. So I'm going to give you a few examples. And I'm a pediatric provider, so it's going to be a little short story time. So story time. My first patient that I'm going to talk to you guys about is that as an infectious disease provider, I'm consulted to evaluate pre-transplant patients, so children that are going to need transplant. And part of that evaluation is seeing what vaccines that would best protect them going into transplant. And I had this patient that the parents were completely against, hesitant to do any vaccines. The patient had been unvaccinated at that time, but they were more than willing and really geared up to go forward with liver transplant and all the medications that are involved with liver transplant. And it was an opportunity that I was able to employ a question that I've used all throughout my career, which is, what is your greatest fear about the vaccine? And it may seem like a simple question, but it really opens yourself up that, again, you're inquisitive, you're open, you're non-judgmental, but also you get valuable information of exactly where is this hesitancy coming from? What are the barriers standing between you and vaccine acceptance? My next story is actually about a colleague, and it was a social worker that joined me on a patient case. That patient had complicated pneumonia and required IV antibiotics as an outpatient. And we also had the opportunity in that particular case to talk to the parent about vaccines that may prevent the patient from having another complicated pneumonia. When we left the visit is when the social worker pulled me aside and had mentioned to me that she learned so much about the MMR vaccine during my just simple discussion with the patient, but also that she thought the MMR vaccine was linked to autism. So it really presented to me, one, where the pulse of some of my providers were at with vaccine confidence and being able to give that strong recommendation, but an opportunity to have a true evidence-based discussion. I find with my colleagues that trust me and rely on my consultation, it's easy to get into these conversations, present them the literature and where you stand. The word strong before your recommendation holds a great deal of power. My last story actually deals with low health literacy. I had a patient that had been referred to me to evaluate whether or not they had an immunodeficiency. In fact, the patient did not have an immunodeficiency, but I found that in trying to review the labs, the family just wasn't catching on about these different parts of the immune system. And so I also had to tie in how vaccines play into the immune system. And my favorite way of approaching this is to use metaphor and storytelling. And my favorite metaphor and story to tell in regards to explaining the immune system is to describe a castle that has several barriers to an attacker. And when you give a vaccine, it allows those soldiers to not just use a sword against a big monster, but then they learn how to use a bow and arrow, a cannon, a laser beam, whatever it takes to defend against such an aggressive attacker. And that generally gets me traction and understanding of where these vaccines interplay and really what they do with the immune system. Each of these examples presents opportunities to have difficult conversations, to nuance your talking points and get shots in arms. If we want to prevent further spread of the virus, we must make every effort to bolster our vaccine practices and to best protect our children and communities. Thank you.
Well, thank you, Dr. Chatani. And I love the way you instill vaccine confidence in your patient. I love the way you approach it, and also love the way that you use every encounter with just about everybody as an opportunity to improve vaccination and talk about the benefits of vaccination. And do I hear remnants or that this might be a start of a children's book on why you should get vaccinated with some of those little stories?
For sure. There are some really good children's books out there, like hardcover books on antibiotics and bacteria. And there's one on immunizations. I absolutely love it. Amazon has everything, right?
Well, so do you, Dr. Chatani. And we'll now move on to questions from our audience. And many of you already submitted questions when you registered, but if you didn't submit a question early, you can still post your question online in the chat section, and we'll try to get to as many of them as we can. Now, the first question is for Dr. Chatani. What constitutes an exposure to a patient with measles?
It's a great question and very important that we recognize when we should be concerned about an exposure. Close contact is really what the definition boils down to, that you're within 6 feet of an infected person for at least 15 minutes or more over a 24-hour period.
Dr. Rosenthal, this one's for you. Did you see any secondary cases because of your exposures in your hospital? And maybe could you tell us some of the details of where and how these exposures happened?
So fortunately, we did not have any, we're actually proud about that. We did not have a secondary exposure to measles here in our facility, but we did have one near miss. There was a patient who something just went wrong in the screening, or something did not really work, and the patient was not isolated, ended up having a negative measles. But once we were concerned that there might have been an exposure, we went through the exercise and we started preparing for a possible exposure. So I can, of course, describe that. So first of all, we needed to see how long the patient was in the waiting room to make sure that we have enough to see how long of an exposure we had. As you know, there's not really a set time for exposure for measles. We wanted to see who else was in the waiting room, who else was in the area, and we needed also to define what is the exposure area. We actually looked at the air handling systems in our ED to see what would be the exposure area that we will be looking at. We made a list of patients that could have been exposed and healthcare workers that could have been exposed. And we made a list to see which were immunized and which were not as a preparation for a possible need to give post-exposure prophylaxis. That's just to begin with. And we were very happy to hear that the measles turned out to be negative.
Well, thank you for that answer. Dr. Boyle, based on your experience, what was your biggest roadblock during this outbreak and how did you overcome it?
I think Dr. Chatani actually stole my thunder, but I would say in my experience, one of the biggest roadblocks around this work is vaccine hesitancy and also being a pediatric provider. But the way that I've found to overcome it is really building a rapport with patients. Again, that every encounter being an opportunity to not be a missed opportunity to talk about vaccines, even if that's not why they're coming in, just infusing that information, because you just never know when someone's coming in for a sore throat, but for some reason, that discussion that we had might be the day that, they want to have that vaccine. And really talking to patients regarding vaccines, answering questions, addressing myths. MMR is one of the bigger ones next to COVID, I think, that had the most pushback from, parents and patients. It's usually parents that I'm talking to for underage patients. But I also found that one of the things to help overcome that was discussing their concerns, but it was actually very helpful for them to hear from providers who are from their community, from similar cultures or background regarding the decision to move forward to vaccinate their children. So that has been helpful.
Yeah, and when Dr. Chatani was giving his presentation, just laid it out there to the patient or to the family. What is your greatest fear about this vaccine? Getting them to tell you what they're concerned about, and then you can address it and dispel the myth. Dr. Filardo, are you still there? I hope so. Can you give us some advice on how to communicate with and educate adults who have not yet received a measles vaccine series?
Well, I think we encounter the scenario a fair amount with adults who don't know their documentation of MMR. Say they haven't kept track of their childhood vaccine records, and in measles contact investigations, it's really common to run across adults who don't know their vaccination status. And I think outside of a contact investigation and sort of in routine care, we sort of message that it's a conversation between an adult and their medical provider, how they'd like to proceed. It's saying that they're going to be traveling abroad or they might be entering employment where they need MMR vaccination. One option would be to do a blood test to look for evidence of measles IgG, which would be evidence of immunity. The other would just be to proceed with vaccination, because there is absolutely no harm in receiving MMR vaccination if you are previously vaccinated or previously immune to measles or any other component of the MMR vaccine. I think if we're talking about adults who know they have not been previously vaccinated, it's really a lot of the same key components that I think Dr. Chatani shared about instilling vaccine confidence, addressing fears, and really meeting a person where they are in terms of trying to encourage prevention and vaccination. Really, on the adult side, I think it's quite similar to the pediatric side. How you approach that conversation should it be needed.
So what about adults that were born before 1957, particularly when we're seeing all these international outbreaks? What do you tell those people?
Yeah, ACIP and CDC are pretty clear on this, that we think that the vast majority or almost all adults born before 1957 would be immune to measles. And that's because before the vaccine was introduced in the early 1960s, really the presumption was that every American during their childhood had measles. And having had measles really confers lifelong immunity. So we don't recommend vaccination for that group necessarily, and we don't recommend sort of going to your provider and getting a titer drawn for that population. It's really across the board, with the only exception being healthcare providers. It's across the board considered a presumptive evidence of immunity.
Well, thank you for that. Maybe both Dr. Boyle and Dr. Chatani can weigh in on this one. How does a history of vaccination affect the triage screening process? Dr. Boyle, why don't you start, and then we'll follow with Dr. Chatani.
I think vaccination history helps. It would be one of those questions I was talking about in the checklist that you would ask. I think it would help depending on the symptoms, because as we know, measles presents like a lot of other things. So I think it would help with illicit differentials, placing it sort of lower on my differentials if someone was fully vaccinated. As Dr. Rosenthal mentioned, sometimes when children have one vaccine, it hasn't created enough of a level of immunity to protect them fully. So we know that they need 2 vaccines. So not only a history of vaccination, but to ensure that they were completely vaccinated. But that is how I would utilize that information in terms of building up differentials. So it could be, a lookalike like Kawasaki or something like that.
Dr.
And
Chatani?
I would add to that just the other end of after exposure. If it's a
Yes.
post-exposure case, it's vital. It's absolutely vital in determining management of whether you're going to be giving immunoglobulin, how you're going to isolate them. Everything is hinged upon whether or not they were immunized.
Thank you. So we now have a question from the chat. Dr. Rosenthal, can you talk about the measles exposure cases you saw, and did you give the vaccine as post-exposure prophylaxis?
So we, if the question is about the measles cases that we saw, so we did ask the parents and close contacts of our measles patients if they were vaccinated, given the fact that, as I said, the Department of Health provided already vaccinations for unimmunized patients. Many times they already got the vaccine, so we didn't need to give a post-exposure prophylaxis. And many of them actually came vaccinated with 2 vaccines from their home countries and from before. We took a very detailed history. In regards to other post-exposure prophylaxis, when we had for example, when I described the exposure that we had in one of our neighboring clinics, then we just helped the clinic identify who needed the post-exposure prophylaxis depending on their immune status.
Thank you. Dr. Filardo, what are the recommended tests for diagnosing measles?
Yeah, thanks for that question. So CDC recommends a combination approach for diagnosis. The most important test, we think, is to perform PCR-based testing for measles, and to really do that at the first opportunity, so as early as possible after the rash onset for the case. Measles PCR can be done on a nasopharyngeal or oropharyngeal or throat swab specimen, and can also be performed on urine, but generally only in conjunction with an NP or an OP swab. And then in combination with that, we do recommend, if possible, to perform measles serology, so testing for measles IgM to look for evidence of acute infection. Adding in serology can help in cases where maybe the testing happens later after rash onset, where you might not be as reliable to detect measles by PCR, but you can really detect IgM then. So the 2 testing modalities kind of work together and complement each other quite nicely. So we recommend that combination approach.
So you mentioned the rash. Can you explain when you're infectious before the rash begins?
Sure. The infectious period for measles is defined as 4 days before rash onset. So rash onset is considered day 0. And then you go back 4 days before rash onset, and you go 4 days forward from rash onset. And there's not a lot of evidence of asymptomatic measles transmission, at least available in the literature. But given that it can be quite hard to define really when somebody's symptoms started, especially those prodromal symptoms that sometimes can be mild, It's really not determined based on when symptoms start, but just purely on that rash onset.
Thank you. Dr. Rosenthal, this one is for you. What should we do if a clinician diagnoses measles, but then the test comes back negative? And how did you handle it when the clinical suspicion didn't match the test result?
We actually had two similar cases. So first of all, any test is not perfect. So you can have a false test. But first, the diagnosis of measles is a clinical diagnosis. So if a physician had a high index of suspicion in an unvaccinated child that they might have measles, and really the entire presentation and the risk factors fit measles, I think clinically we should continue with treating this patient as if they have measles. However, if there was a soft diagnosis, the patient was vaccinated, not really known exposures, we deal with it a lot, that the test ends up being negative, and we need to help kind of identify the mimickers. What are the other things in the differential diagnosis? How bad it would be to misdiagnose Kawasaki's, for example, with the conjunctivitis, the fevers, the rash. It's important to go back to the drawing board, think about differential diagnosis, and treat the patients for what they actually have. Many times it might be just a viral infection and a different virus that we might not identify, but really go by the clinical suspicion and, as any test, see if it might be a false.
Thank you. Dr. Chatani, what are some of the best practices for outpatient clinic screening?
For outpatient clinic screening, I think we've kind of touched on that with the other presenters as well. Just having those set questions that you're going to be asking at the front desk. I know some practices that have tried to utilize the telemedicine triage or the call before triage, and sometimes it works, sometimes it doesn't work, depending on your patient population and how they interact with your clinic. But yeah, having those set questions is really what's going to best identify who you need to be concerned about and who you need to refer.
Dr. Boyle, I'm going to add this last quick question for you. Is there any difference in the triage or infection prevention steps in an acute care hospital versus a nursing home? And that's the last question.
Yeah, I'm pediatric, so I haven't spent a lot of time in nursing homes, but I will say in terms of infection prevention control, if we're talking about standard and airborne precautions, I mean, we have set things we know that works. So that should be in place and should not be that different. What may differ, obviously, are the mobility and the ability to move patients, sometimes for isolation. I know for measles at times when we're talking about long-term care settings, cohorting may need to happen if you really, run out of space or something like that. But you may have more medically fragile patients. And also the other thing that I know has come up, and it just was some work that I did in the past, if we're talking about older patients, if the patients have dementia, you may have to isolate a patient, but they may forget this isn't their room anymore or something like that. Putting things in place to aid them so that they remain in isolation. So some of those are nuanced things that may come up, and depending on the facility type and space and real estate that you have to put things in place so that standard and airborne precautions can take place.
Well, thank you. And unfortunately, we're out of time for today's session. This discussion has been so informative. Many thanks to our panel of experts for sharing their stories and their experiences with us. And many thanks to all of you for joining us today and for your great questions. We've learned so much today from hearing about these experiences of being on the front line of this year's measles outbreaks. Early recognition, effective triaging, appropriate infection prevention and control measures, and a strong measles vaccine campaign can make a big difference in handling this and future measles outbreaks. A video of this event will be available on this page shortly. For more information about AMA's work with Project First Line, visit amafirstline.org. We look forward to seeing you at future educational webinars. Thanks again for joining us, and have a great rest of your day. For the American Medical Association, I'm Dr. Sandra Fryhofer.